Long COVID has become a significant concern worldwide, and understanding its impact and finding effective interventions is crucial. We are pleased to have Professor Angela Cheung, a renowned expert in the field, guide us through her research and findings today. Firstly, I would like to invite Director of PolyU Academy of Interdisciplinary Research, Professor Cheung Chen, to deliver the opening remarks. Please join me in giving a warm round of applause to Professor Chen.
All right, thank you very much, Professor Chen. And ladies and gentlemen, good morning. It's really my great pleasure to give these opening remarks. You probably know that COVID, just happened not a long time ago, and Hong Kong just will open the border less than 1 year. And we are still suffer quite a lot on the consequence of COVID, such as long COVID, the speaker will talk about today, and also associated problems like mental health issues. Today, we also have Professor Hector Sam here, who is the director of a mental health research center. So some of you might not know the PolyU Academy for Interdisciplinary Research, we call PAIR. PAIR is a organization established 2 years ago at the PolyU, try to address the major societal issues like the 17 Sustainable Development Goals set up by the United Nations for 2030. And one of those goals is about health. And at the PolyU, we have 6 research institutes and research centers working together to address this issue. And especially for the Research Center for Chinese Medicine Innovation, or we call RCMI, have worked very hard on this, such as the stereoprosthesis. Also, Professor Cheung works on that. It's a very important topic. And they also find out some important issues like how to use Chinese medicine to improve that. And the other major topic they worked out is on the metabolism. So all of those are using the Chinese medicine and the related technologies to address the health issue of Hong Kong people and also the nation and the entire world. So I believe today's lecture is very important, and our speaker just arrived yesterday, and then the first thing in the second day is to give this lecture. I think that's really a wonderful thing to have. So I'd like to just pass this speaker phone back to the MC.
Thank you, Professor Chen, for setting the tone for today's lecture. Now let's move on to the introduction of our esteemed speaker. I would like to invite Associate Director of RCMI, Dr. Daniel MOK, to introduce our speaker. Dr. MOK, please.
So thank you very much. So today is our honor to have an expert in long COVID to share with us her experience in conducting studies on these important issues. As Professor Chen mentioned, this long COVID affect many different areas, including maybe cognitive performance and other health issues. So we believe that Chinese medicine as a holistic approach may be a good way to deal with this. So therefore, we also have an in-house long COVID studies, and we are very glad that Angela is coming here to share with us their experience in studying long COVID. Professor Angela Cheung is Professor of Medicine, as well as the KY and Betty Ho Chair in Integrative Medicine at the University of Toronto. And she is also the Senior Physician Scientist at the University Health Network. She has held many awards, including Canadian Institute of Health Research, Senior Investigator Awards, Canadian Society of Internal Medicine, David Sackett Senior Investigator Award, Ontario Premium Research Award. So it's a long list. So maybe I stop in here. So she has been the working on long COVID. She is the principal investigator of CANCOV, a national longitudinal cohort study of COVID-19, and reclaim the adaptive platform trial for intervention for long COVID and the long COVID web, a national research network for post-COVID condition. So she has been served as advisor for the Public Health Agency of Canada. So her extensive experience in this area is a very important for us. So today we are very glad that she is coming here to Hong Kong and share with us the experience of long COVID in Canada and the 3 projects that she launched. So let's welcome Professor Angela Cheung.
Thank you very much. Thanks for the introduction with Professor Chan and Professor MOK. I'm here to learn. So I can share with you what we have done in Canada, but I'm here to learn. I was on campus probably in the 70s. And it is very different. Like now, like I came today, I walked up the steps. It's very grand and like saw the central, I don't know what you call it, like a ground with grass. It's beautiful. You have a beautiful campus. So Professor Wong has actually been to University of Toronto, and we were exchanging sort of some of the things that are that's happening where I am, and also she was sharing with me some of the things at Hong Kong Polytechnic University as well. So thank you for this invitation to talk about some of the work that I've been doing. So I'm going to concentrate on long COVID in Canada. So before I start, I want to show you sort of what my disclosures are in terms of industry involvement and also non-industry. I've been working with governmental agencies like Canadian Agency for Drugs and Technologies and Health, the COVID Immunity Task Force, the Public Health Agency of Canada, the Chief Science Advisors Task Force and that office, Ontario Science Table, which is the province that I live in, and I currently hold 3 grants around long COVID. So what I'm hoping that after this session, you will be able to define what long COVID is, identify the mechanisms underlying long COVID, describe the factors that protect against long COVID, and manage the symptoms of long COVID, and also discuss some of the latest research on long COVID. So in Canada, it's estimated that there are 2/3 of the population, or 64.6%, has had acute COVID. And that amounts to about 25 million people, because in Canada, we currently have close to 39 million people. And there have been 57,000 deaths. And a recent survey by the Public Health Agency of Canada, together with Statistics Canada, it's estimated that there's 3.5 million long COVID cases just in the 10 provinces. So Canada has 10 provinces and 3 territories. And so just in the 10 provinces, we estimate there's 3.5 million long COVID cases. The first case, the official case, was on January 25th, 2020. It happened in Toronto because we have a lot of people flying everywhere in Toronto. But actually, if you look at my studies, the first case was actually identified in October, so about 3 months earlier. So these are photos from the initial sort of, January to February time of 2020. And you can see all the various measures at at immigration, sort of airport checkpoints and in emergency rooms, EMS, emergency medical services. And even in the public, like they closed playgrounds, they did a lot of different things. And I can tell you that, COVID really changed medicine forever. So I am a general internal medicine specialist or internal medicine specialist, and I do research. And so at the time I was doing acute care, and this quote reminded me. So this quote is from Arthur Ashe, who is a Black tennis player, and he was the first Black American who won multiple Grand Slams. He said, start where you are, use what you have, and do what you can. And so at the time, prior to COVID, I am a researcher interested in women's health, especially postmenopausal health, and also musculoskeletal issues like osteoporosis. So what happened is, at the time, I, talked to my colleague. I have a colleague, my colleagues, and they have networks. And I have a network of internal medicine specialists across the country. And so we talked about what can be done quickly. Can we pull everyone together to do this? And so this is how it started. We started something called the CANCOV study. It's a Canadian multi-center observational, you can consider it a platform study. It's a longitudinal cohort study. But we collected everything. We collected clinical data, we collected, work data, healthcare data, we collected blood samples for genomic studies, transcriptomic studies, proteomic study, and it's still ongoing. So it was initially funded by University of Toronto because they put out this competition for seed funding, and we then later got federal funding. And then there's the RECLAIM trial. It's a platform randomized controlled trial. More recently, over the last year, we also were able to get federal money to establish the Long COVID Web as well, which is a national research network. So I'm hoping to tell you a bit through my presentation about these three projects. So, but I want to sort of define what long COVID is first, because different people have different thoughts about long COVID. The WHO case definition, which was put into place in October 2021, described long COVID as post-COVID condition. That's the official term. And that it can occur in someone who has a confirmed SARS-CoV-2 infection. SARS-CoV-2 is the virus. And so when you test with PCR or with antibody tests, you basically is a confirmed case. But there are so many people without access to these testings. So that's why WHO actually includes the probable case. And they define long COVID as having symptoms after 3 months of the infection. So the acute period is described as the initial first 3 months. And then after those 3 months, if you have symptoms still lingering, it's long COVID or post-COVID condition. But it also has to last at least 2 months. So it's a recurring thing. It can't be something that happened for a day or two and disappear. And the other important definition to this is you can't have an alternative diagnosis. So for example, you have migraines, and yes, your migraine is worse. That doesn't mean that you have long COVID. So it's important to think about alternative diagnosis. And I can tell you, we have diagnosed ALS in patients, we have diagnosed diabetes, new hypertension, and many other things, but those have alternative diagnosis. It's because there are a whole group of symptoms, as many as 200 symptoms that are vague, difficult to put a finger on. So fatigue, shortness of breath, cognitive dysfunction, or what people call brain fog, are the common things. And it can fluctuate over time. You can get better and then it relapses and gets worse as well. So that's the WHO definition. But it's called many different things. In the US, it's called post-acute sequelae of COVID-19, or PASC. And CDC in the US define it as after 4 weeks. So not the 3 months or 12 weeks, but after a month. And so there's some variation depending on country, but I think there's some agreement that it is something that lingers on, that affects sort of long term. And there are other sort of terminology as well: long COVID, long haul COVID, post-acute COVID syndrome, chronic COVID, long-term effects of COVID-19. Canada adopted the WHO one, the terminology of post-COVID condition. And based on Statistics Canada, in their Canadian COVID-19 Antibody and Health Survey in 2023, 19% of adults who have with a confirmed or suspected infection experience longer-term COVID symptoms. And about half of those have symptoms that last longer than a year. And 1 in 5 of these adults also experience long-term symptoms, that their symptoms are often or always limiting their daily activities. And so this is a huge issue, not only for health, but also for the economy, for the workforce. And there are early retirements, people on disability, and couldn't work. And so this is a huge problem in Canada. So let me tell you a little bit about CANCOV. So it's a Canadian national study across 5 provinces. So British Columbia, Alberta, Manitoba, Ontario, and Quebec, and involves more than 100 investigators. We were able to use the government money to recruit sort of 2169 participants before we closed in March of 2021. We're still following these people, but we're no longer recruiting. We actually don't have the funding to recruit. So there's 3 cohorts initially: the non-hospitalized cohort, the hospitalized cohort, and the hospitalized cohort is divided into the non-ICU cohort and the ICU cohort. The sicker that you are and you require ventilation, mechanical ventilation, you will be in the ICU. So that's the differentiation. And most of those people have what we call ARDS, or acute respiratory distress syndrome. Because of patient advocacy, we actually had to add the clinical cohort, which we have 459 patients in there. But these are people without a confirmed, test. No PCR test. So I want to show you that these are the 3 cohorts that we initially have. And we use 6-minute walk. So 6-minute walk is a test that basically we timed 6 minutes and have someone walk and measure the distance. There are national data to compare sort of how the patient did to what is predicted. So this is the vertical axis is % predicted, and it's based on age, sex, and other parameters. And on the y-axis is a time axis. So 1 month, 3 months, 6 months, 12 months. So not surprising, the green one did worse, right? So the ICU folks did worse initially compared to those who are just hospitalized, compared to those who are not hospitalized in the blue line. And over time, over a year time, you can see that everyone improved. But what was surprising was the non-hospitalized group never quite go back to about 100%. And so that was the first indication that there's something wrong with even those with quote unquote mild infection, at least not requiring hospitalization. So the people in the hospital, we give them steroids, we give them various things, and in the ICU, we put them on ECMO, which is basically a blood exchange to oxygenate when the lungs are too bad. We even do lung transplants for some patients in the ICU who did really badly. And so because of all the things that we do to people, it can cause what we call post-ICU syndrome or post-hospitalization syndrome. And so the cleanest cohort to look at long COVID is those who didn't get all those things and was not sick enough to be in the hospital. And so if you look at that group, at the 3-month time point, 22% of patients actually have fatigue. And 16% have cognitive changes. They have brain fog. And a lot of people, 8-9% have, shortness of breath and chest heaviness, chest pain, and chest tightness, and fast heart rate and other issues. So you can see there's actually a fairly large percentage of people with lingering symptoms. Clinically, for the non-ICU cohorts, we diagnose a lot of new conditions, but we can't say that they are higher than sort of normal public. But we see hypertension, cognitive changes, and diabetes. We also get myalgia encephalitis, or what used to be called chronic fatigue syndrome. One of the hallmarks of chronic fatigue syndrome, or what we call MECFS right now, is post-exertional malaise, where people, if they do too much, they crash. And when they crash, they have to rest for a few days and sometimes weeks and sometimes months to get better. We see a lot of dysautonomia, and inappropriate sinus tachycardia, postural orthostatic tachycardia syndrome, mast cell activation syndrome. And we see a lot of neurological issues like tremors, myoclonus, seizure, dysbasia. Dysbasia is the feeling of, like you're on a boat. You're walking in the classroom here, but it feels like you are wobbly and on a boat. And we also see reactivation of other quiescent infectious disease like EBV, Epstein-Barr virus, like syphilis I saw in one of my patients. And so all these things are quite disturbing for the patients. In the ICU cohort, the outcomes are fairly similar to our previous research around ARDS, or acute respiratory distress syndrome. But the mortality is higher compared to those. And it's around sort of 40 to 60% mortality. So 60% for those on ECMO and about 40-something for those on mechanical ventilation. But the difference between usual ARDS and this is actually neurological issues. So what is the mechanism underlying long COVID? Well, we know that the SARS-CoV-2 virus entered the cells via something called the ACE2 receptor. This was actually found in Canada. One of my colleagues in Vancouver worked on this and realized actually this virus entered the cells via the ACE2 receptor. And what we learned is that the ACE2 receptor is everywhere. It's in your nasal passages, in your lungs, in the gut, in the heart, in the eye, in the liver, bladder, kidney, pancreas, brain, and even in reproductive organs like testes and prostate and placenta. And so it's no wonder that you are getting all these sorts of symptoms in different organ systems. There's also a paper that outlined what the normal function of ACE2 receptor is and what the disruption to ACE2 receptor can cause. And so that really matches up in terms of the symptoms that we see with long COVID. WHO listed 7 causes of pathogenic mechanisms: inflammation, immune dysregulation, endothelial dysfunction, viral or viral particle persistence, thrombotic microclots, mitochondrial dysfunction, and also perturbations to your microbiome in the gut. So I'm going to just highlight a few of these papers. There are thousands of papers on this. This is a very recent one from January 2024. So this month, earlier, a few days ago, it just got published. And because I'm interested in musculoskeletal health, this looks at muscle abnormalities after sort of you stress someone and they crash. So it's the post-exertional malaise in long COVID. And there are definitely muscle abnormalities. There's inflammation, there's myeloid type kind of accumulation in your muscle. And actually by pushing it and doing sort of crashing more, it is actually makes it worse as well. We also have this study is done by my colleague, Doug Fraser in London, Ontario. Is using proteomics to look at long COVID patients. And it basically discovered that the HIF-mediated vascular proliferative pathway, meaning it bothers the lining of blood vessels. And so it's no wonder that people get problems in the brain and in the heart. And you can see that is quite different depending, these are proteomics signatures. Those with mild COVID versus long COVID versus severe COVID versus healthy control in the population. And the long COVID signature is very different from the others, those who actually recovered from COVID-19. There's also papers on persistence of the protein, the S1 protein, the spike protein, in monocytes in patients with long COVID. And that persistence was found up to 15 months. And so that's why there are many lines of discovery. And I think because of COVID, we actually have learned many different new scientific pathways as well. So how can we prevent? Well, if you don't have COVID, you don't have long COVID. So it's that simple. And how can we prevent that? Well, masking would help, vaccination would help, and good ventilation would help. This is the vaccination systematic review against long COVID. And you can see that if you have 2 or more vaccinations, it will improve or decrease your risk of long COVID. This is the other factors that may be affected. So we know that Omicron, which is what's circulating right now. By the way, COVID is not over. I still have my mask, and in crowded areas I will use. Yes, Omicron is less in terms of the risk of long COVID, but there's so many more people with Omicron. And so that's the absolute numbers resulting from Omicron in terms of long COVID is actually a lot more than the Alpha and Delta strains. If you're a woman or female, you have a higher risk than males. If you're between the ages 35 and 65, you're also at higher risk. If you take Paxlovid initially, you actually have less risk of having long COVID. If you also take metformin, for 14 days, pretty high dose, 500 milligrams 3 times a day on the acute side of long COVID, then it also reduces your long COVID risk. That's done by a colleague of mine in general internal medicine in Texas, US, called the COVID Out study. So prevention is better than cure. And currently there's no cure for long COVID. So how do we manage long COVID? So this is what I teach healthcare providers. You need to listen and validate the symptoms. You need to assess and diagnose, discuss the potential treatments, consider patient preferences, and do joint decision-making. So these are 2 people with long COVID. They have been fairly vocal and they lead these support groups. On the left is Susie Golding, who started a Facebook group with now probably 40,000 people, advocacy group. On the right is Jonah McGarva. And he's from BC, she's from Ontario. And both of them, what they hear from patients is that healthcare providers don't believe it because you can't do a test to diagnose it. And most of the time when you do your regular blood test, it looks normal. And so a lot of patients complain that the doctors doubted and dismissed them. And 60% say people are just ignoring them. So it is a pretty bad situation in Canada. So what we did with some of my mentees is doing sort of articles on how to diagnose, how to assess, and how we can treat. And this is published in Canadian Medical Association Journal, 3 articles, very short, sort of 5 things to know. And so that practitioners can quickly sort of understand what long COVID is. So one of the major things is fatigue, but it's not like you have a, long flight and you feel tired, or you have a long day and you worked hard and you feel tired. This is called myalgic encephalitis. And one of my colleagues who have long COVID, Dr. Anne Barrera from McGill, Quebec, used this analogy. It's like your cell phone. You're so used to it running 100% all the time. But now it can only run 15%, maybe even 10% or 5%. And you need to make it last the whole day long. And because once it's done, you crash and you can't do anything. So that's the difference between the usual fatigue and this long COVID fatigue. It's called myalgic encephalitis and chronic fatigue syndrome. So what do we address? How do we address this? Well, we make sure that people have adequate rest, have fluids, adequate nutrition, and help patients adjust their activities. And so one of the, I see a lot of patients, some of them are my colleagues who are physicians, and one head of department who have long COVID came to me and said, he's a surgeon. So he said, I'm not working anymore. I'm not standing in the OR for 10 hours. I don't do this. I'm listening to you and trying to rest. And so I said, okay, so what are you doing right now? He said, well, I went to my cottage and I chopped wood. And I said, that's why you're not getting better. You're not resting. And so, and I hear common stories about women as well. So they say, oh yeah, no, I quit work. I'm trying to listen to you and rest and pace myself. And then they're like running around, shuttling the kids from one thing to another and cooking and things that they don't usually do because when they're working, they couldn't do these things. So that's not resting. So I have to work with people to figure out sort of what working is like. Okay, so what happens is this is the trajectory of long COVID. If you actually stop this yo-yoing, so at the acute state, you didn't feel well, you rest for a few days, then you feel better. But if you do too much, you crash again. And so it's like this thing. And when you crash, you have to rest again, and then you go up again and feel better, and you try to do too much, and then you crash again. But if you stop this yo-yoing, you can actually slowly improve. So we sort of talk about threshold and staying under the threshold. And if you stay under the threshold, generally, even without much treatment, you will improve. But if you keep yo-yoing and crashing, you actually tend to do worse, and this curve goes down. This is from a CEO. And I asked him to draw me a clock, and this is what he drew. And so like this, it's not difficult to figure out that someone has cognitive issues. And this is what the person drew for me. And this is someone who actually is very, works at a very high level as a CEO. So we actually, because when you do CT scan, MRI, you don't see anything. You see some non-specific white matter changes. So we actually devised a new protocol called the CVR protocol to look at, you think of it as a brain stress test. The top one is healthy controls. The bottom one is someone with long COVID. There's a slowness of response in the brain. And so, you don't need to be, MRI radiologist to read this. You can tell a difference even by the color mapping that there is a problem in the brain. So this is not someone just, thinking that they have a problem, that is all mental issues. This is actual problem in the brain. We see a lot of insomnia and sleep disturbances. So we teach a lot of sleep hygiene and sort of like, and we use melatonin and magnesium for relaxation and other things as well. We see a lot of headaches, this is sort of what I teach my medical students in terms of how to assess it. Is it migraine type or tension type, and how to treat it as well. And I won't go over all those as well. We see a lot of post-viral cough. That's the easiest to treat. So we do have symptom treatment. So using puffers and nasal sprays, those will treat the sinus congestion and the post-viral cough. But what we don't have is a cure for long COVID. So one thing one of my colleagues, Cheung who is a professor of medicine in respirology, he actually ran spirometry in our population and found that even those with mild COVID, they have a restrictive issue, meaning they can't take deep breaths. That's why when they walk, they feel short of breath. So I have marathon runners who come to me and say, I'm very scared because I used to run 10K marathons and now I can't walk a block without being short of breath. And so what we found is it's a muscle issue. And so we teach them breathing exercise. I actually teach them a little bit about Qigong to try to work on the muscles and also to really modulate their autonomic systems as well. So shortness of breath is very common, and we have videos. In the last few slides, I also have something on CANCOV that teaches people how to do breathing exercises under the patient resources. Cardiac MRI. So people complain of chest pain, and stress tests can be bad for them because it makes things worse. So cardiac MRI shows that, so on the left is the normal scan. On the right is a cardiac MRI that shows myocarditis. And so, but you need 4 criteria for the diagnosis, what we call the Lake Louise criteria. By the way, Lake Louise is in Canada as well. Beautiful area. If you happen to sort of go, it's a beautiful area to visit. So there are 4 criteria called the Lake Louise criteria for diagnosing myocarditis or endocarditis. And most people don't satisfy all the criteria, but they have 1 or 2 of those criteria. And so we can tell that there is a problem as well in the heart. In the clinic, when I do examine someone and stand them up with what we call the 10-minute stand test, you can see that there's blood pooling in the legs and their heart rate goes way up. And so usually a normal person, your heart rate goes up initially and then comes back down when you go from a lying position to a standing position. But these people have high heart rate for more than 10 minutes. And there are ways to treat it. You make sure people have adequate fluids, adequate salts. You use compression stockings, and then you can use certain drugs as well. So one of my colleagues leads these guidelines called the Canadian Cardiovascular Society Guidelines on Long COVID, and talk about cardiac dysautonomia and POTS, and really sort of basically this is something that we follow. Our group has done, some of my mentees have also done a review on the long-term cardiovascular outcomes published in Canadian Journal of Cardiology, and also sort of like how we should manage people with long COVID as well. So these are articles that may be of interest to you. And bottom line is we have to think about sort of the dysautonomia in the heart, and think about sort of POTS and IST, also mast cell activation syndrome, and also think a little bit about sort of the usual cardiovascular conditions like ischemic heart disease or other things as well. Mental health is an issue. So those who have a history of mental health issues will have more problems with mental health, because now they are like, oh, I don't know like how long I'm going to be like this. Am I going to be like this all my life? And so there's a lot of anxiety, depression, and also PTSD, post-traumatic distress syndrome. And you can use cognitive behavioral therapy and plus or minus medications to treat that as well. And recent studies have shown that people with long COVID have lower serotonin levels. So serotonin is a compound a hormone that actually affects anxiety and depression. And so we can treat with certain medications. And so this actually is another step towards our understanding of what's happening in long COVID. So let me close by talking a little bit about some research in Canada. And I sort of advise everyone, if you have long COVID, there's lots of things we don't understand and we don't know. And I advise people to do something meaningful to help find solutions together. So we have patients, partners in this. And one of the reasons why people would like to participate in research is it gets them access to new tests and experts that's not otherwise available. So there's a RECLAIM trial, which stands for Recovering from COVID-19 Lingering Symptoms Adaptive Integrative Medicine Trial. And we currently have 100 patients in the trial. That is the drug trial, targeting inflammation, immune dysregulation, and endothelial dysfunction. So below our website and how to find us as well. In the RECLAIM trial, we're hoping to have a Chinese medicine arm. And so, I'm here to learn. So maybe later on, discuss a little bit about these things as well. We are interested in looking at other therapies other than drugs. And so traditional Chinese medicine is something that we're interested in exploring. And this is the long COVID web, and I brought a poster that I can share later with you all as well. It's a research network. Currently, there are about 700 members, about 250 researchers, another 250 clinicians. You're welcome to join as well. So this is, it's at www.longcovidweb.ca. So in summary, post-COVID condition is a real multi-system physical condition with mental health consequences. There are interventions to prevent and also treat the symptoms. There are no cure yet, but we are in search of a cure right now. And there's lots of exciting research going on, understanding the pathophysiology and on treatments and mechanisms and other things. So, it's kind of like, different groups around the world trying to figure out what is this big elephant in the room. It's like, the 10 blind men feeling an elephant. It's a spear, like when it's feeling the tusks. It's a rope when you're feeling the tail. So it's a little bit like that right now, the situation. And so I'm hoping that we can work collaboratively, internationally, to really put all those pieces of puzzle together to really find answers and solutions to long COVID. And with that, I thank you for your attention.
We will now move on to the Q&A section, when we will have the opportunity to ask questions and engage in a meaningful discussion. Moderating this session, we have Associate Director of RCMI, Dr. Daniel MOK. Please join me in welcoming Dr. MOK to the stage.
So thank you very much for the comprehensive talk on the long COVID symptom, as well as the studies that Angela has been conducting. So any questions from the floor?
Thank you for the talk. It's wonderful. I know you mentioned that the long COVID cases, it's in the high risk between 35 to 65. But I just wonder for children and, adolescents, what kind of situation it is for long COVID?
So we see a lot of adolescents with long COVID. I think the risk in young kids is difficult to ascertain because, these are very vague symptoms of like, a bit short of breath, fatigue, and those sorts of things. But in general, I think around the world, people feel that we in Canada don't have a good grasp of the pediatric population. So all I showed you was adults. I don't actually have kids data, and that's actually something that we're working on. So in the adolescent group, even in the post-acute setting, we see something similar to Kawasaki disease. And so another Hong Kong Dr. Ray Yeung, Professor Ray Yeung, who's a rheumatologist, pediatric rheumatology, was the international expert in Kawasaki. And so early on, really see the similarity between Kawasaki and MISC, multi-inflammatory system in kids. It's MIS-C, and basically use immunosuppressive drugs to treat. And then other than the more acute situation of MIS-C, that is, kids will go to the hospital and get hospitalized for it. We are also seeing some long COVID as well, but we don't have a good grasp of how big the problem is. In general, we feel it's less than in adults.
So in other words, I can probably interpret in other way that, pediatric population or adolescents, they are probably more like, we call it probably plus, they have a wild adaptation of change of things and to improve their health and so on and so forth. So that's why there's no obvious symptoms that can be easily identified as what we see in older adults and so on and so forth, right? While the older adults, that means that older adults, even we call it long COVID, symptoms or, impacts, that probably also due to a lot of other complications that they already have in their in-house. So that there's quite complex interactions with prehistory, health history before COVID came in. Is it something that related to that, or I'm just very curious why COVID perhaps may have different impacts to different age for the population.
Yeah, I think there are many factors. You're right, there's plasticity in children. So, and the immune system reacts differently as well. But I can tell you, I've seen kids who can't go to school. I say kids, but I see like in the teenage years. Any sound, any noise really affect them as well. So they lie in the dark all day long without not even looking at the computer. So that's how the parents knew there was something wrong, because usually they're like, going on the computer and looking at YouTubes and TikTok and other things. But they weren't. They were lying in the dark with earplugs in bed all day. So like I've seen several of those kinds of patients. So I think it can affect children for sure. But the rates are lower than adults. And for adults, we actually see a lot of healthy adults that don't actually have any disease. So no comorbidity. They don't have diabetes and hypertension and all those sorts of things. And they got long COVID. So it's not something that we know the answer to right now. We think there's some genetic predisposition. Maybe those who are predisposed to autoimmune disease may get it more. Maybe those who have genetic predisposition to not only autoimmune but microclots. Like maybe there are various factors involved. But diabetes, hypertension, chronic obstructive pulmonary disease or COPD, those are issues that actually put people at higher risk of hospitalization during the acute phase. But they definitely are not the same, putting them at risk for long COVID.
Thank you so much.
Thank you.
Thank you, Professor Leung. So I'm Hector Cheung from the Department of Rehabilitation Sciences, and we have commissioned a long COVID study in Hong Kong that we will be sharing with you later on. Now, I would like to have ask you one question: is that now because your CANCOV study is pretty similar to what we call the study 1 of our commission study. And we are studying, the symptom profile of those with long COVID in Hong Kong, of course. So I would like to ask, do you have, any information or comparing the differences of the symptom profile, among, different ethnic people? Like in Canada, I know you have multi-ethnic people. So do you have that kind of data, or have you, talk to experts in Asia or in the Oriental context, that there are any differences in some symptoms of long COVID? Thank you.
That's a great question, and it's a question that I ask, but I can't answer. So I wonder about racial ethnic differences in the CANCOV study. Other than sort of Toronto and Vancouver, with high population of non-white population, it's most of the other sites. So we have 18 sites, and other than the Vancouver site and my site, with a high proportion of non-white, all the others are very sort of white population. So we have not had a chance to look at sort of racial differences. Yeah.
Mhm.
And actually, I approach Statistics Canada and Public Health Agency of Canada to see if we can look at their survey to see if there are differences as well. Yeah. So to be continued. I don't have the answer right now. Yeah.
So thank you. So I think this is, maybe one of the area, because we have data, we have quite, data accumulating in Hong Kong.
Yeah.
And basically we are ethnic Chinese.
Yeah.
And you have data, basically from Canadian and
compare,
also,
for
yeah,
sure.
and right. So I think maybe we do not have, such a big sample as in your CANCOV study. You have more than 2,000, and we have about, 400 right now.
Mhm.
So we can talk about that later.
Sure.
Thank you very much.
Thank you.
With it.
Thank you, Angela. It's very interesting. I have quite a few questions, but let me just ask the basic one first. You mentioned about high dose metformin for the treatment initially. Can you tell us, how it works?
So, so one of my colleague, James Russell, and who's an ICU intensive care unit physician, worked on a few studies looking at proteomics of long COVID as well. I didn't present his data, but his data, this is in Vancouver, showed that it's actually along the glucose metabolism pathways, especially initially. And so I think there is something to this idea of, if you fix abnormal glucose metabolism initially in the acute COVID state, you may prevent long COVID. It was a secondary outcome. So it was the COVID out trial is really trying to see if the treatments can prevent hospitalization, decrease mortality, and so on and so forth. And metformin did not. did not decrease mortality, it did not have any effect on outcomes in the initial acute COVID phase. Then they added as a secondary outcome, well, let's see longer term, what happens? Do people recover from the acute COVID and it's okay, or develop long COVID? And what they found is if you start the metformin within 3 days of the acute COVID, your chance of reducing long COVID is very impressive, like 70%. If you start it within 5 days, it's lower, about 0.5, so 50%. And so it's, and beyond 5 days, I don't think there's much effect. But the course that they used was 14 days, 500 milligrams 3 times a day. It's a cheap drug if it works, and it's pretty safe, but it needs to be proven in another trial because it's a secondary outcome.
Thank you. The other thing is you talk about a long list of complications for long COVID, and you have these neurological like tremor and things like that. Is there any study on that and how they could be treated?
So depends on what the symptom is. Currently, all of us have been treating symptomatically. So we use Parkinson's drugs for tremors. So it depends on what the neurological symptom is. Brain fog is very difficult to treat. So there's no treatment right now. Some people are trying the Alzheimer's drugs, but I haven't seen any data out yet. So there are symptomatic treatments for all these various symptoms, but we don't really have something that will look after everything. And so we're doing trials right now to try to see if we can find something that target the pathways, the phosphodiesterase pathway, the MIF pathway, it's called migratory inhibitory factor pathway, and also the toll-like receptor pathways. So we know certain pathways in long COVID, and we're trying to target those by repurposing drugs that are already out there.
So in fact, later on, we will discuss with Jerry on the use of acupuncture, because some of the theory with regard to the symptoms may be like autonomic nervous system, vagal nerve, and there are evidence to show that acupuncture can help with,
Yeah. So I'm currently working with Linda Sang, who is now working at the Singapore Linglam, the university in Chinese medicine. And we're working on looking at doing a systematic review of acupuncture and for various symptoms. And hopefully that can be presented sometime. I've been working with them on that. And, I think we really need to acupuncture is very common here in Hong Kong, but it's not as well accepted. It's probably more accepted than traditional Chinese medicine herbal therapy outside of Hong Kong. And so I have always been a proponent of trying to get really well done studies, randomized control studies or systematic reviews or whatever, into the Western literature. New England Journal, JAMA, the top journals, so that it's more known around the world.
Thank you.
Okay, so I think we have another question from the audience over there. Yeah, please.
Thank you for your insightful presentations. This is Dr. Shahnawaz Anwar. I'm from BRE. I'm working as a research assistant professor. As you said that it is difficult to cure long COVID. So I think we can, if we monitor their symptoms from the beginning, so we can manage them in better way. So keep in that mind, we are conducting a research on the evaluation of wearable sensors for monitoring symptoms of long COVID for their tracking their symptoms, and we want to develop a some machine learning models for detecting and classifying severity of long COVID among older adults. So, but we have questions that how long we should monitor them for the like using variable sensor for 1 day, 1 week, 1 month, so that we have enough data for modeling, because we don't have any data related to recovery time of long COVID. So how I have questioned that how long should we monitor them for enough data?
So in the human side, I can only talk about humans. I don't know much about mice or hamsters and those sorts of things. So in humans, some people have had it for like 3 or 4 years. And if you use the definition of 3 months in human years, that basically that's the cutoff for the definition of long COVID. If I'm doing a study, I would at least do 2 years in humans, because some people will recover by 12 months, as shown in our CANCOV study, but many actually don't. And I think it's that crowd that is the problem, because the ones who can recover, if they are going to recover, great, you know that giving them some time is good, and they will recover. But the crowd that still have long COVID despite all the symptomatic treatment, that's the problematic crowd, and we need to find some solutions for them.
Okay, thank you.
So maybe, well, I asked the last question. So you mentioned there's some study proteomics trying to identify the differences in the proteome of a long COVID patient compared to a patient fully recover from COVID. So I just wonder, I mean, for the proteins that they identify, does that relate to the symptoms that you observe, or just a marker without any biological?
That is a great question. The whole microclot issue, I wonder, right? So I have patients coming to me asking for triple therapy. So triple therapy in my world means an antiplatelet treatment, 2 antiplatelet medicine, and a anticoagulant. And that the risk is high for bleeding. And so I have patients asking those sorts of things, and I'm saying, I don't even know if this is really the cause or bystander. And without sort of proper trials, I'm concerned about giving you something like that, because I can cause more harm by having a bleed in the head and you have a stroke than benefits per se. And so exactly, like the proteomics point to something, but we don't know.
Okay.
And so is it a bystander issue or is it the cause? We don't know.
Okay. So I think that means we still have a lot to
There's lots to learn.
do.
As I said at the very beginning, I'm here to learn.
Okay, so let's thank you, Professor Angela Cheung, again for the inspiring talk. Thank you.
Thank you all for your active participation in the Q&A section. Now, as we are near to the end of our lecture, I would like to invite Dr. Daniel MOK to present a souvenir as a token of appreciation to Professor Angela Cheung. Professor Cheung, Dr. MOK, please.